worksite health clinic records, and it's something that we really need to break it down from a legal perspective, an operational perspective, record retention, and all these different things. So whenever we're working with new clients about medical records and occupational health records in a worksite health clinic, before we can even get started on, what legal requirements apply, what operational considerations apply, what vendor should we use, we really have to build our framework. And so these are the questions that I have put together to kind of go through. And I would really recommend that if you're starting a new clinic or analyzing how you are going to handle medical records, that you put together a spreadsheet or a list and really sit down and answer each of these. And we're going to go through some of these today. So, I think the point being, before you can figure out how to handle records, you have to understand your services and who provides those. For who provides the services, if it's a physician versus a mental health counselor versus a nurse practitioner versus a pharmacy on site. Those are all going to have different record requirements for the healthcare provider versus the employer. So again, we're going to walk through some of these today. One thing we're not going to hit on in as much detail today, though, is cybersecurity and security requirements. And so the last three questions I want to touch on before moving on, because that really goes to the cybersecurity aspect of the records. But where is your health information stored? How secure is that? Does your vendor have a SOC 2 or high trust CSF certification? Who has access to that information and who should actually have access to it? And how is that health information transmitted? For example, is it encrypted in transit and at rest? So these last three are really questions that need to be put into a broader cybersecurity framework. So the services impact the records. It's, again, really critical you first understand your services, because depending on the services, it will impact how we need to retain the records, who gets access to the records, what are the legal requirements for storing those records and making certain reports to public health authorities or OSHA or a workers' compensation carrier. So these are the way I categorize services for purposes of records. I think you can break down a lot of these in much more detail, and you could also add services, but these are really kind of the main ones as far as record keeping. So from a primary care and non-occupational health standpoint, right, you're really going to be more worried about that if you're the healthcare provider. What are your record retention requirements? What are the access requirements if you're simply providing primary care at a clinic? As the employer, you're really going to look to the vendor to help you manage that. I noted pediatric services on height here because a lot of the worksite health clinics we work with allow services to be provided to dependents. And so anytime you have services being provided to dependents, you're going to get into record keeping issues with minors. So in some states, record retention requirements for a minor are much longer than an adult. And then there's also a whole nother issue as it relates to which parent or both parents having access to those records. What if there's a custodial dispute? So if you are going to allow minors into the clinic, this is something you really need to think through as to how those records are being stored and who has access to them. And that really goes hand in hand with consent to treatment by a minor too, which varies in all 50 states. Occupational health services, this is a big one. So for the occupational health, and we'll talk about this in a little more detail, OSHA has its own record keeping retention requirements and its own record keeping reporting and all these different requirements related to records. So if you are an employer, you're going to have to understand what are your record keeping retention requirements under OSHA, what are your reporting requirements, and who's handling those? Is this something you've delegated to your clinic vendor? Are you working with an EHR that specializes in occupational health that can help with some of these? Workers' compensation and DOT physicals, very similar to the occupational health, in that is going to be governed by certain state and federal laws. We'll talk about those in a little more detail. Mental health services, this is a big one. We're seeing more and more on-site clinics and hospitals provide mental health services for their employees, or for the employees that go to those clinics. If you are providing mental health services, Not only does the provider need to be aware of HIPAA and some of the nuances under there for psychotherapy notes and treatment, but also each state is going to have different laws as it relates to mental health records. So again, very important. So we'll go through the rest of these, but just, really building that framework and answering those initial questions is key. Okay, so location matters. As we build our framework to figure out what do we do with these records, how do we legally comply when we're holding and giving access to the records? One big thing is location. So there are really three main questions we start with here. One, what state is the clinic located in? That is going to govern a lot of the regulations. For example, if your clinic's in Indiana, you may have different regulations governing the mental health records, consent to treatment, things like that. But just because your clinic is in one state like Indiana, if you have patients located in other states, those patient records will likely be governed by the state where that patient resides as far as access to those records, treatment, things like that. And then I put the international patients in here. This is becoming more and more of an issue. I think we're getting GDPR questions every day. But if you run a clinic that provides telehealth services overseas, or if you have a meeting overseas and you're using a clinic vendor overseas to manage the COVID-19 testing services, maybe at that event or that work meeting, you need to think about, are the services provided to international patients? So do you have patients traveling to the US from other countries? And likewise, are you providing telehealth or on-site services in other countries? One of the big keys with the international aspect is there a transmission of data, so of medical records from another country, let's say Brazil, Canada, or Scotland, to the US, so what we call a cross-border transaction with records. That right there is also going to trigger additional obligations. So whether you're the employer or the healthcare provider, understanding these is going to be really critical, or at least working with a team that does understand these and has the right legal framework in place. Okay, the legal puzzle. I don't know how else to put it other than it's a complete puzzle with Worksite Health Clinic. You almost have to layer on the requirements, right? So in your traditional clinic, you'll have the employer or the health plan that contracts with an on-site clinic vendor, and then you're going to have typically a separate EMR company too. Sometimes you may have an employer that manages its own clinic. And so depending on which hat you're wearing, that's going to dictate what laws apply. So for example, if you are the healthcare provider that is providing services and you are conducting standard transactions and considered a covered entity, HIPAA will apply. If you are the health plan, of course, HIPAA applies. If you are the employer, HIPAA may not apply to the employer because the employer is not a healthcare provider that conducts standard transactions in most cases. And so you may not be concerned about HIPAA from the employer's compliance, but you need to be concerned that your vendor is complying with HIPAA and that they are properly shielding that employer from information or not. And so that was just an example to show it really depends on, what lens we're looking at the laws from. So running through these real quick, state laws are critical. And I think sometimes people forget about state laws when they go through the analysis of what laws apply to their records. So each state is going to have their own privacy and security laws. So Indiana, put up a link there. CCPA under California is a very sweeping privacy law. And if you have any patients that reside in those states, for example, if you have a clinic that may be serving patients in 20 different states, you need to understand the privacy and security requirements in each state and get ahead of those. Don't wait until something bad happens to learn those. From a state law perspective, record retention and access is also very critical. So most states govern how long healthcare providers need to keep records, and that may vary in each state. And again, it may vary if we're holding minors. And so if you are an employer that's managing their own clinic, or you are a healthcare provider that provides on-site services, you're going to need to understand that from a national overview and adopt either a national policy that encompasses all the laws or state by state. We usually think of HIPAA governing access to records if there is a covered entity that has control of the records, but don't forget about your state access laws. Those are going to vary by state too. And even though generally they're in line with HIPAA, there are some states that may be different or that may require different consents or authorizations for access to records. So OSHA, of course, is a big one that governs our occupational health records from a federal perspective, and there's also various state requirements. I should pause and say we tried to put in hyperlinks here because clearly we cannot go into all of these laws in detail. This would be a 5 or 8 hour seminar if we wanted to talk about all of them. So we really hope that you can use this as a resource for your clinic to work with your advisors on as you look at records issues. EEOC and ADA. If I was just speaking to the healthcare providers, I may not include this, but given that this is also a seminar for employers, I think it's really important for everyone to think about the impact that the EEOC and ADA has on records. So, for example, if there is a medical examination conducted to determine if there is a disability or a return to work scenario, you are going to have certain restrictions on who can order the medical examination and who has access to those records. And so again, a few helpful links there as far as things to review. The next one is the U.S. Department of Labor. U.S. Department of Labor, for the first time ever, rolled out new cybersecurity guidance that we'll go over here in a few minutes, and the link is there. Let's see here. I'm going to do just 3 of those. So Office of National Coordinator, ONC, rolled out the Cures Act and the information blocking regulations. Information blocking regulations we're going to talk about in a few minutes. I would point you to the GDPR here. And last, I would point you to the NIST cybersecurity framework. I note that this is voluntary guidance, but if you are getting into the technicalities of how records should be maintained from a security standpoint, it's really a gold standard and something also that your vendors should be very familiar with. So we're going to spend just a couple of minutes on HIPAA. Again, we could do a whole session on this, but from an employer or a vendor perspective, what you need to think about first is the employer or vendor a covered entity? And so is there a health plan? If it is a health plan, it is a covered entity. And then I put this in there, providers who do not conduct standard transactions. So a standard transaction is like an electronic billing. If you're submitting claims to Anthem, let's say, and I know a lot of vendors do submit claims, others don't. If you are submitting claims, you are a covered entity under HIPAA. One thing that I think is a little unique about Worksite health clinics is sometimes you will have a provider, a healthcare provider, who does not conduct standard transactions, and therefore they may not be classified as a covered entity. So before you even start down the road of HIPAA compliance, really dig into whether you are a covered entity or not. But I'll warn you, even if you are not considered a covered entity, most employers that will work with you will want you to treat the records as if they are covered by HIPAA. It's really a best practice, and most state laws are going to mirror HIPAA too. So even if HIPAA doesn't require it, your state law might, such as an authorization to release records. So protected health information can be utilized without an authorization for treatment, payment, and healthcare operations, and subject to other limited exceptions involving law enforcement, subpoenas, and things like this. All other disclosures require a HIPAA-compliant authorization. I want to talk about 2 issues under HIPAA specific to Worksite health clinics. So if you are a Worksite health clinic that provides occupational health services specifically, there is an exception in HIPAA for disclosure to the employer that I would really advise you to review. So if you are a covered entity, an on-site clinic vendor, typically you can't disclose medical records of the employees to the employer. So if the HR manager or another director walks into the employer and says, hey, I want to know why Stephanie Eckerly was out the other day, can you give me her medical records? The answer is no, unless there is a HIPAA compliant authorization. But there is one other exception that's important. If healthcare is provided at the direction of the employer to conduct an evaluation related to medical surveillance of the workplace or work-related injury, so really your OSHA type of work, and the protected health information consists of finding only related to that OSHA surveillance, and the employer needs those to comply with state or federal law. If the patient has received notice that their PHI will be disclosed to the employer, that can be released to the employer. And notice needs to either be given to the patient, or you need to have a sign that is very prominent at the Worksite Health Center about this. I know a lot of Worksite Health Centers that do have these signs and rely on this exception, but I will warn you, I think of this as a backup exception, right? It can be utilized, but here's where you can get into trouble. If you have an employee that comes in, they're treated for their OC health issue, they hurt their back while working on the factory line, but they're also seen that day for their depression, or because they think they have the flu, right? And you have all this in one record, well, you're going to have a HIPAA issue then, because you can't disclose the non-occupational health records under this exception. So you want to be really careful if you're using this to, train your staff and really have a good segregation of records. The Office for Civil Rights also recently came out with brand new guidance on COVID-19 vaccination records. I put a link there for anyone that wants to review it. So some key takeaways from this, and I would really advise everyone on this phone to review it if you are dealing with requesting an employee to disclose their vaccination status, or if you are storing vaccination records. But employers can require that employees disclose their vaccination status. Employers can actually require that employees are vaccinated, although there are some exceptions to that, such as accommodations for religious and disability. If you have documentation of vaccination status as the employer, that must be kept confidential and separate from the employee's HR file. So again, it really goes to that segregation of records. But if a covered entity provides healthcare services to the employer and the covered entity has that information, they must obtain a HIPAA authorization to disclose that vaccination status or record to the employer. So again, it depends on what hat we're talking here. Do you have your employer hat on, or do you have your on-site clinic vendor hat on? We're going to spend just a minute or two here talking about another very new rule, the information blocking rule. This was found in the Cures Act and became effective in April 2021. We haven't seen any enforcement come out about this yet. So here's one of the big issues. Information blocking applies to electronic health records. Unlike HIPAA, the information blocking rules apply to all healthcare providers, not just those healthcare providers that conduct standard transactions. And the Office of National Coordinator has been very, very clear on this. So employers, if you have a healthcare provider that you are utilizing to run your on-site clinic, or if we have on-site clinic vendors on the call, please look at these new information blocking rules. Information blocking is a practice that will interfere with, prevent, or discourage access to information. And so the goal really here is to provide both patients and providers access to their medical records. One of the key takeaways is that patients must be given immediate access to records when requested unless an exception applies. And those exceptions are listed here. I'm not going to go through all of them. If you'd like a more detailed example of any of these, happy to provide that with you. And the website that we linked at the beginning has a lot of information here. One of the ones I hear the most about is preventing harm. And so where this really comes up is if you have a patient that requests their lab records and you're worried that it's a bad result, let's say to a cancer screening or a biopsy, right? Can you deny the patient access to those records until the provider has the opportunity to talk with the patient? Generally, the answer is no, unless it fits into this very, very narrow exception for preventing harm that has a lot of other requirements, such as it has to be an individualized determination. So you can't have a blanket denial for sensitive test results. And again, this is also going to be subject to state law when you're thinking about test results and access. Why do we care about information blocking? Because to be honest, I get that question too. Well, it's going to impact how and when employees can access their own PHI. It impacts your relationship with your healthcare vendors. It applies to all healthcare providers. And maybe what most of my clients care most about is the Office of Inspector General, or OIG, may enforce or will enforce these rules and may impose civil monetary penalties for violations. And the portal to report violations has already been opened. One thing when we're thinking about access to records, we talked about how you have to build your framework, and it's really an overlay of different laws here. Well, under HIPAA, you have 30 days to respond to a records request. Under OSHA, for OC health records, in most cases, you have 15 days. And under the information blocking rules, you must respond promptly. So how has information blocking really changed our landscape here? Well, under HIPAA, my client could respond as a healthcare provider 20 days after the request. Even though that's still allowed under HIPAA, it is not allowed under the information blocking rules. It needs to be as soon as possible. And if there's a portal, you need to push those records to the patient portal if there is a request made by the patient. DOL cybersecurity guidance, another one that is going to govern your records. I included this on here because this applies to plan sponsors and plan fiduciaries governed by ERISA. So if you have a self-insured health plan that maybe contracts with your on-site clinic vendor, the Department of Labor new cybersecurity guidance will apply to you. And there's really three key focuses there. Tips for hiring a service provider, such as an EMR company, cybersecurity program best practices, and then online security tips. And I think your guidance is actually really helpful. I would encourage you to look at it. It's well written and it's somewhat concise too. Okay. So now that we've been through the regulatory framework and we touched high level on some of the main regulations, I want to talk to you about retention and ownership of records. When you engage your on-site clinic vendor, it really needs to be clear as to who owns those records and what are those record-keeping retention requirements. And this really goes back to what type of records are they? So providers, you are going to have an obligation under state law to maintain records, maybe for 7, 8 years. You may have a longer obligation under some payer contracts, and you may have an even longer obligation if you are providing services to minors. Employers, you are going to have separate record keeping and retention requirements under OSHA. This can be up to 30 years. And so you really need to, again, break down what type of records you have and what are those record keeping retention requirements. One of the big things when we're thinking about who owns the records, where are they stored, how long do they have to be stored for, is what are the obligations for retention upon the termination of the vendor? So if we have an employer on the webinar today, you may think, well, my on-site clinic vendor, my healthcare provider, is responsible for those records, so I don't need to keep separate copies. And that may be true from the perspective of primary care, but if that on-site clinic vendor is providing occupational health services, they may be under the impression that you, employer, are responsible for retaining those records under OSHA, which you are. And so there needs to be a really frank discussion about who's going to retain those and what happens if you part ways or terminate with that clinic vendor. Will they easily transition those new records to the new clinic vendor? Will they still keep a copy for their own risk management and comply with their own retention requirements? So thinking through how that works is going to be critical. And I should say too, I don't think we said this at the beginning, if anyone has questions, if you want to put those in the chat box, when I'm done with my session, I will check those and answer any questions, or Jeff and Mike, if you're able to review those and you want to jump in with questions that anyone has, please let us know. So access and privacy. Again, I know I keep saying understand the legal framework, but it really matters here as to who has access to those records. You need to think about the access rights of the employer versus the healthcare provider. So again, most employers do not have access to primary care records without a HIPAA compliant authorization, but they may have access to occupational health records if we have either received consent from the patient, if you have a covered entity providing those, or if the employer provides those directly, they would have a right to access to. But it's really going to be different. Department of Transportation, DOT, has different laws on that. And it can also be very industry specific. So for example, NASA, the astronaut program, they have their own record retention requirements. Railroads, some of those have their own record retention requirements. So it's really not just are we looking at the federal law OSHA, but even different industries. Billing and payer considerations. When you're building out your framework for records, you also need to think about who is the payer. So there's going to be certain requirements for billing. You may need to use certain codes. You may need to keep certain information in the medical record to show medically that it was a medically necessary procedure, or to show the unit of time associated with that encounter. And so you really need to understand what are the payer requirements in order to have the proper records, what are the record retention requirements of the payers, and the segregation of records is critical for proper billing. So if you have a clinic that has both primary care, OC health, and DOT physicals going on all at the same time, when that patient comes in your clinic, you really need to understand what is this service related to, what records need to be kept, because you need to make sure that you're giving the proper records to that third-party payer. And you also need to think from a record-keeping perspective, if you get a request for records, who's responsible for that, both payer and internal audits. And then lastly, another key issue for records is analytics. So analytics, we hear a lot about it. If you were just at the NAWHC conference, there was a lot of talk about data analytics there and the different things that employers and vendors can do with that data to really improve the health and wellness of their population. But one thing to think about is most of the time, not all the time, but most of the time, in order to get really good analytics, you have to have really good records, right? And then who gets access to those records to run the analytics, to run the reports, to see how you could decrease prescription costs, to see how you could increase utilization of your clinic. If it is a third party, you need to think about, are they able to legally access those records? So if you have a healthcare provider that's a covered entity that is going to be providing access directly to those records, is that legal? Are there the right data sharing agreements in place? Are there the right business associate agreements in place? If the health plan is the one contracting with the healthcare provider, you know, have we shielded them from personally identifiable information or protected health information? One thing to think about too with records is the proper de-identification of aggregated data. I probably every year, a couple times a year, someone calls me and they talk about how they're going to de-identify the protected health information in their clinic in order to be able to use it for data analytics. And so we ask them, okay, what do you mean by de-identify? And it's like, well, I'm going to take out the name, the date of birth, and their street address, but leave in the city and state. That probably won't work. So under HIPAA, there's two ways to de-identify information, either through removing 18 identifiers or through an expert opinion. So really making sure that things are properly de-identified if you are using aggregated data. And then security and privacy risk of utilizing records for data analytics. Anytime you're using records, you're always going to be very thoughtful about the cybersecurity risk there. And so the more vendors you are allowing access to those records, such as a data analytics company, you know, the more vetting of those vendors you need to do to ensure that they have the proper security requirements in place, such as the SOC 2 or everything being encrypted in transit, and to make sure you have the proper agreements in place. Okay, EMRs, EHRs, and PHRs. And I'm going to thank Mike for this graphic because I really like it. There is a million to choose from. And again, to set the stage here, it's really going to be critical that you think about the services you are providing. If you are only providing a primary care clinic that has nothing to do with occupational health, that may have one EMR that will be different than if you have a clinic that combines occupational health and primary care or just has an OC health focus. And so to talk about EMRs, EHRs, and PHRs, we have Jeff Donnell, the president of Enterprise Health, who can really put together the framework on what you need to be thinking about if you are also providing occupational health services in your clinic with primary care or solely OC health.
Great. Thank you, Stephanie. Yeah, my name is Jeff Donnell, and as Stephanie said, president of Enterprise Health. And we're actually an electronic health record company that focuses specifically on the occupational and employee health niche. So we primarily work with large employers that operate their own on-site employee health clinics, or also with third-party service providers who provide occupational and employee health services to other employers. And we work in the corporate arena. So some of our clients are people like Chevron, Dow, Disney, JP Morgan Chase, Cargill. In the hospital and health system segment with people like Houston Methodist, Northwell Health, Ohio Health, and then also in the government space, primarily working with federal government agencies, people like the Department of Energy, NIST, and folks like that. And typically when we work with a large employer, we find that there are sort of 2 domains that typically oversee occupational and employee health. In some cases, that responsibility reports into environmental health and safety. Other times, it's kind of a corporate health and wellness domain, often reporting in through HR. It's not uncommon for it to be a little bit of both and for it to change over time with a number of dotted lines. And in many cases, organizations aren't quite sure exactly where it fits. And I will certainly say that pre-COVID, occupational health in many cases was sort of that clinic in the bowels of the basement that was a converted broom closet. And of course, COVID has changed the calculus dramatically. Now people in the C-suite know who is in charge of occupational and employee health. And COVID has certainly put a fine point on the critical importance of present, productive, and healthy employees. And we find that across this continuum from environmental health and safety to corporate health and wellness, our clients tend to do a little bit of everything. Certainly, there's a lot of focus on occupational health and compliance. And in many cases, our clients first put a clinic on site to make sure that if somebody got hurt on the job, they were managing them appropriately, that they were collecting information for OSHA, and that they were managing things like medical surveillance, making sure that people were getting the proper tests and exams tied to the risks and exposures that were part of their job. But increasingly, we're seeing that our clients are also saying, well, we've already leveraged the investment in a clinic to do occupational health. Let's provide primary care services. Let's get into chronic disease management. Let's do health and wellness services. And while our clients have tended to start with the occupational health side and gravitate to the right, we also know that in many cases, people are starting with health and wellness and disease management and primary care, and then also layering in occupational health and compliance. So it's certainly a bit of a mixed bag. Next slide, please. Yeah, so for enterprise health, because we sort of cover this entire domain, when we back up the truck, we have to be able to provide a full range of occupational and employee health functionality, as well as a lot of the clinical functionality that you would find in just about any ambulatory clinic. So next slide, Steph. So as an example, you're going to find on the occupational health side, certainly functionality to manage, as I said, worksite injury and illness and do the appropriate case management. A lot of work around medical surveillance, making sure that people have the proper tests and exams, whether it's exposures to chemicals, hearing conservation tests, pulmonary function tests, DOT physicals, and a lot of this is industry specific. And again, a lot of that worksite injury and illness and medical surveillance has historically been driven out of the need to make sure that you're compliant with all the rules, regulations, laws that Stephanie reviewed here for several minutes. But again, increasingly, we're starting to do clinical care, but also very important is employee engagement and supervisor engagement. Extremely important to make it easy for employees to be able to share health information, schedule their own appointments, get access to their records. Again, Stephanie mentioned the information blocking rules. So it's really critical that an employee be able to download their own medical records at a moment's notice. But also you want to be able to make sure that supervisors know the health status of their employees. While supervisors can't see their employees' health records, they are entitled to know whether or not their employees have had their required surveillance tests and exams so that they're certified to work. You need to be able to know if an employee has a worksite injury or illness, are there restrictions or accommodations that supervisor needs to be aware of. So a good occupational health solution will be able to manage all of those things. Next slide, please. In addition, then in a good employee health IT solution, you're going to find the functionality that you would expect to see in any ambulatory EMR. So a lot of the things that you would expect to see from a solution from an Allscripts or a Cerner or an Epic, you're also going to find in most employee health solutions. And that's, routine things like document management, tasking, e-prescribing, reporting, those sorts of things, but also things that maybe bridge the gap between both the clinical side and the occupational and employee health side. For example, mass immunization functionality. Historically, our clients used our solution to manage annual flu programs in the fall. But of course, that functionality has expanded now to account for administration of COVID vaccinations, which many employers are taking responsibility for. Also getting into things like travel management, especially for international employers. But again, now with COVID, that has bled over into domestic travel as well. But also looking at things like ability management, absence management, those sorts of things. Next slide.
Jeff, what is ability management, just to clarify for anyone on the call that may not know, including myself?
Yeah, so that really gets down to, is someone certified and able to do their job? It also will tie into absence management. So is someone fit for duty, and often after a worksite injury or illness?
Thank you.
Sure. Okay, if you could go to the next slide. Perfect. Mm-hmm. And I will say that what we find is that more often than not, employers are managing occupational health and employee health not on a single solution. It's typically a commercial application, but oftentimes people are doing things on homegrown databases, spreadsheets, even on paper. And typically when we deploy our solution, we're retiring 6 or more different legacy applications, solutions, and processes. And we have heard horror story after horror story over the last 18 months of people trying to manage COVID for their employee populations using spreadsheets and paper. And that might have seemed like a good idea early on when people thought that, oh, this will be a 3 or 4 month ordeal. But of course, now that it's a true global pandemic that is stretched on for almost 2 years now, people are realizing that if you don't have a good digital infrastructure to manage occupational and employee health, you're going to have a significant challenge. The other thing that's important is that typically our solutions will interface with a wide variety of different applications. So it's not uncommon when we deploy to interface with a corporate HR system, or in some cases, multiple HR systems, email applications, labs, medical devices, immunization registries, workers' comp carriers, just about everything but the kitchen sink. And what we found is that most employers want to be able to take data from a wide variety of applications, data that often resides in silos, and or in silos, and be able to have all of that on a single application so that information is accessible, actionable, reportable. Next slide, please. The other thing that, of course, has become increasingly important over the last 18 months is functionality around COVID. And certainly in our case, all of the people that use our products are the people that are responsible for managing employee health for their organizations. So these are the people who have been on the front lines of managing COVID for their workforces for the last 18 months. It has been a significant challenge, when whether you're a corporation operating an on-site employee health clinic, or a hospital or health system who wants to make sure that the people taking care of patients are themselves healthy and productive. It has just been a nonstop roller coaster ride. And we all know that guidance has changed. It seems that every week there's some new direction, new guidance. You have to be able to turn on a dime. And we don't see any signs of that abating in the near future. And all of our advisors are telling us to expect this to continue until probably about mid-year next year. And I know for us, we've had to be incredibly agile to be able to support our client community. Early on, many of our clients pivoted right away to telehealth. All of a sudden, when you don't have people on site, but they still need to have care, so they're not coming to the clinic has to go to them. So we deployed telehealth rapidly for many of our clients who were not using it. Symptom monitoring has been huge. Every day, literally millions of employees of our clients are going to a mobile application or a portal, and they are reporting on symptoms. They are doing that before they go into work. They're getting a little badge on their phone that tells whether or not they're cleared to work that day or whether or not they have to stay home. And based on that determination, then there's robust case management, because in many cases, if someone can't come to work, if they show positive for symptoms or they have positive exposure, then it's up to the employer to do case management and manage them all the way through the return to work process. COVID testing was really, really big early in the pandemic. It kind of subsided for a while, and now it's back with a vengeance, because for people who are monitoring employee vaccination status, in many cases, if employees are not vaccinated, then they're required to get testing on either a weekly or biweekly basis. And management of all that has to be done electronically so that you ensure compliance. We've done contact tracing, a lot of work around vaccine administration, and of late now it's adding in boosters. And right now, probably the most significant thing we're doing with our clients is around vaccine tracking, enabling employees to upload proof of vaccination, to manage consents and declinations. And then if someone is not vaccinated and that's a requirement, then making sure that they get testing. And then a lot of work around compliance, around reporting, and with this, back to interoperability and interfaces. We have now interfaced with, I think, every immunization registry around the United States. Every state has their own registry. In some cases, even cities and counties have their own registry. So that's been a requirement in order for employers to be able to get a steady supply of vaccines. So it's just been, as I said, a nonstop roller coaster. But it's like being in one of those roller coasters where you're sure that somewhere down the line there's some missing track and you just can't see it coming. Next slide, please. All right, so let's kind of bring this back to and tie it into some of the things that Stephanie was talking about in terms of just key considerations around the medical record. And as Stephanie said, we're very mindful of OSHA requirements. And, there's certainly OSHA on a national basis in the United States, but a number of states in the U.S. have their own state OSHA requirements that in some cases are a little bit more stringent or different from national OSHA requirements. And then because so many of our clients are global, we have to be aware of the OSHA counterparts around the world and what their requirements are. And while many countries, follow pretty closely what goes on in the United States and what OSHA is up to, it is different everywhere you go. As Stephanie said, you have to be very, very aware of state and local requirements. And most of our employer clients operate in multiple states. So you have to make sure that the health IT infrastructure that you have is able to recognize where care is being provided, where are employees located, and what are the guidelines that you have to be aware of and manage around. Also, HIPAA is incredibly important, and a number of our clients are covered entities, especially hospitals and health systems. But as Stephanie said, even if say a large employer is not considered a covered entity, we still operate as though they are in terms of security, privacy protection. It's just kind of best practice to assume that HIPAA best practices should be applied everywhere. We're also very, very aware of healthcare legislation. So Stephanie gave the example of information blocking. And this is a situation where, information blocking rules, were really kind of developed for ambulatory and inpatient care, but they apply to all healthcare providers. And it's not entirely clear what those requirements are when it comes to occupational health records. And because it's not entirely clear, we really operate as though we're working with a hospital or a physician practice, and you have to make it easy for patients, and in this case, employees, to be able to get their hands on their information and to do so very rapidly. Again, because we're
Hey, Jeff.
Yes.
Oh, on that note, I was on a webinar with Office of National Coordinator listening, and in the chat box wrote, if you have an OC health provider that works just for like an automotive company, right? Would they still be subject to information blocking? Because it doesn't really seem to fit. And of course, it was one of the questions that wasn't answered. So yeah, I think we're all assuming they do apply, but it's the framework is very awkward for the occupational health provider.
Yeah, and it's one of those where you don't want to be the poster child where somebody decides, well, hey, we think it does apply and you didn't do it, so we're gonna make an example of you. So better safe than sorry. We're very mindful of global requirements. Stephanie mentioned GDPR. So certainly, for us, because we have global clients, we have to be aware of all the security and privacy provisions around the globe. But again, even here in the United States, we might have an employer that has an employee who is working in the United States from Europe. They are a European citizen. So again, you have to operate under the assumption that GDPR applies. And again, be extremely, extremely conservative in the way that you manage records. And then certainly, COVID has added another layer of complexity. As I said, the requirements are shifting on an almost daily basis. And it has not been at all uncommon for us to see some new guidance that's coming out, whether it's from the CDC, from OSHA, from NIOSH, from a variety of different organizations. We scramble, we work collaboratively with our clients to update functionality. You get it out there, they work with it for a week or two, and then something new happens. And all of a sudden you scrap what you did 2 weeks ago and you head in another direction. And it's just, again, it's one of those, it is what it is. Right now, we're working with several global clients who are doing the management of vaccinations and understanding vaccination status. And what we find is every country is doing it differently. So so those big global clients are kind of handling this on a country by country basis, working with privacy counsel and in those particular countries. And so you have to make sure that you're working with vendors who are able to manage that complexity and be able to house all of that under one roof. A lot of it is, for us, as we work with our clients, we really look at the variety of use cases, right? So every employer client is a little bit different. What a corporate client is worried about is dramatically different than what one of our health system clients is worried about. And as an example, most of our health system clients, our hospital clients, are using Enterprise Health both to manage the health information of their own employees, but most of them also provide third-party occupational health services to other employers. And our application is able to manage both of those populations, but the way that we manage their records, who has access to them, what gets shared with who when, is very, very different. So you have to be able to stay on top of all of that. And a big part of that is understanding the policy landscape at every client. I know Mike will talk a little bit about this, but the policy part is sticky. And as Stephanie talked about, you've got to know the landscape. You've got to understand all the rules and regulations and how they apply. But then ultimately, it's up to each individual employer to develop their policies and their procedures. The other thing that you always have to factor in is the degree of employee trust. We find that some of our clients have really, really good relationships with their employees. Those employees trust that the employer is managing their information appropriately. There's not a high degree of concern. They know that there's good stewardship in place. We have other clients where it's exactly the opposite, where employees are really, really concerned. Who's going to see my information? How do I know that my information is protected? How do I know that my supervisor is only going to see the information that they need about, for example, whether I'm certified to do my job, but that they're not going to be able to see what my conditions are and my medications are. And that even gets a little bit more complicated in a hospital setting. We find that that some hospitals will try to use their enterprise EMR to also manage employee health records. That tends to make people really, really nervous because hospital employees don't want their coworkers to be able to log in to that enterprise system and be able to see the health information of coworkers. And again, some hospitals, it's not as big a concern. Others it is. So you really have to know that landscape. What we find is that the technology is really the easy part. It's getting the policies in place, getting the policy right, and then we are able to configure our technology to support those policies. Really important is making sure that you define user roles, who has access to see what, to do what, when. And then, the other thing is, again, you have to be incredibly flexible and agile. And especially in a COVID world, we have found that agility is really kind of become even more important in some cases than product functionality. It's how quick can you deploy it? How quick can you reconfigure it? Can you turn on a dime with us because things are changing so rapidly? And next slide. All right, and I'm going to turn it over now to Mike.
Yep.
Hey, hi.
Perfect, Jeff. That's what I was going to say. Hi, Mike. Thank you.
Yeah, Mike LaPena. A couple of different things. Stephanie and Jeff both highlighted two major issues. Stephanie displayed some slides and some URLs and convinced me after looking at that there's no way I can understand it. Some of those URLs I clicked on, I went literally blind. So I know that that's a landscape that is left to experts, not to lawyers, but expert lawyers. And then the point that Jeff made over the past year, 2 years, OC Health has changed dramatically. On-site clinics have changed dramatically as we've had the onset of telehealth, changes in the employee population, changes in the role of OC Health, necessary changes, almost battlefield changes. And we see firms like Enterprise responding to meet the needs, no matter what the regulations say, because you have to have people going to work every day and people being well when they go to work and being well when they go home. So it's very, very complex. But the two takeaways, Stephanie's thing is, I'm going to explain it to you, but you're never going to understand it. And Jeff's comment is, it's changing so rapidly, we don't even know what's going to go on. And I endorse both those ideas. They're very, very important takeaways. I'm going to focus a little bit on the data. The data sets really have value. And all of this EMR, EHR, PHR, if you look at some of there are 260 or 280 recognized EMR packages that have that are meaningful use and problem-oriented material that would give you primary healthcare medical records that are appropriate for internists and doctors, hospitals, clinics, et cetera. Very few that really have, like Enterprise, an occupational health orientation that can kind of sort of go both ways, but always can have the OC Health coverage. So again, look at your needs, look at your vendor, look at your EMR. But I want to go to a core issue. Are you choosing the vendor partner for your business? Or are you going to choose the EMR? Because some of the vendor partners that you might consider have their own, and they don't fall on my list. They don't fall on Jeff's list. They are homegrown. Some of them are excellent. Some of them are really outstanding, but none of them are the end result. So these things have real value. Vaccination history, I won't even go into that. The HR demographics, that exists in an office down in the basement in the firm or in the industry. Employee disclosures, dental and vision records, OC Health, and then the linkages to other providers. So these things have real value, but they have a cost also. And I'll have Stephanie click our next example. In the recent past, this is 2019 information, EHR system contributed to bankruptcy at three, that's not MS, it's Missouri hospitals. So that was interesting. I won't tell you the EMR that they all had in common to make you go dig it out for yourself. But these were hospitals that were developing relationships with established EMRs, installing them as they needed to do. And they ended up going bankrupt and going to the bankruptcy court and saying, the EMR took us down. And now, most recently, Google has taken another go at the patient health record software business. I don't know what that means, but we all know that Warren Buffett and his buddies formed a triumvirate here about 2 years ago and said we're going to address electronic health medical records and the use and application of data. And they just about 6 months ago, I think, said, we're out of it. We're done. Google had an EMR at one point in time, about 5 years ago. So did Microsoft. Both of them got out. Now Google's going to have another go at it. I just saw the other day that speaking of the Internet of Things, that Best Buy is developing its own structure for reporting information along a medical pathway of some kind, because they want to be able to be the healthcare store that gives you access to your own healthcare record by any number of devices that they just happen to sell. So taking a look at this, this is a very, very complex process, and the employer or the vendor partner who's going to serve an employer has to be very much on top of this. And the contracts and relationships that are defined are extraordinarily complex. I'd only mention one other term that I think hasn't crept into our discussion yet, and that's the fact that there's sort of a gold standard for primary care called the medical home. And people should take a look at that, because the employers are looking in a book or referencing the literature or calling Larry Boris at NAWIC, and they're saying we should have our health center that we're building and investing in become a medical home. And that raises the level of interoperability to a very, very high standard, very complex. Let's take a look at the next slide and see if we've got some additional information here, because I think we want to wrestle with this as to how we take a look at it. Next slide, Stephanie, please. Okay, at least my information has value or has benefits and risks. That's okay. Let it. I just want to show you those medical records that you see in those two piles were not very well curated, stored. You can't access them. That's the Chatham Clinic in Chicago. Later on, that stuff was picked up by bulldozers and taken to the landfill. But if my social security number was in there and my address was in there, medical fraud represents a growth industry for people who are stealing identities these days. They take my identity, change my address, and start to put claims in. This reflects on the issue of medical record security. But I'll go down, the info benefits. I think everybody knows and agrees upon the benefits. I think that we should highlight one, which is the fact that the medical record and the medical information processing is where you get your measurements for program growth. Every time we talk about a ROI for a clinic, we say more patients, more committed employees, more committed beneficiaries, better ROI. And we can only measure that if we're measuring from the EMR or from the encounter data or from the utilization data. But what are the risks in red? Well, patient health plan security problems, such as you see in this little cut-in, HIPAA, EAP, and OSHA landmines, absolutely. Stephanie was able to scare me to a higher level on her slide presentations on that stuff. The one that really hit me was this blockage stuff. Underline that if you get the slide deck, where it says that the OIG is going to pursue civil and monetary damages. That means that's going to be whistleblower territory. So when Stephanie mentioned they've already opened up the access lines, that means that if I think I was disadvantaged somehow, I can call and get a government attorney to assist me to torture the EMR company and maybe the employer, I'm not sure. This is an area for employer-vendor collaboration or contention, and it is a transition nightmare, an absolute transition horror story. Because when you transition from vendor to vendor, or from hospital to vendor, doctor office to vendor, from OC Health program to an on-site vendor that may incorporate OCHealth, you've got to convert these databases, and the databases are useless unless you're able to convert the software that allows you to access them, use them, and apply the lessons that you're learning from them. Let's hit the next slide if we can, Stephanie. I don't want to be negative on this, but I want to be very thoughtful. So Stephanie, hit that button. There we go. One of the questions, and I think that Jeff covered it very well, that we look at and ask questions about are whether or not there's a high ease of use. Is the record accessible by the patient? I'm on, I sign into every EMR, every PHR, 27,000 patient health record apps available. I'm not sure I have that many, but I do have a bunch of them because I want to see how they work. And I want to see how the interoperability is. And I have, my EMRs, New York hospitals. I've got Mayo Clinic. I go there for my executive physicals. I do my local doctor. I go to Walgreens for my flu shot. If I go to a podiatrist and buy shoes or whatever happens, of course, optician, dentist, is there interoperability? Probably not. Even among those groups that have been working on it for years and spending billions of dollars. Can I incorporate information from my Withings scale? That's what I check every day, one of my indices for healthcare. I got bad news this morning, incidentally. But the idea is that if I'm on one of the more popular apps, these are things that are being adopted by the employees. And so you've got to make sure that your EMR is able to incorporate some of this information to make it efficient for your practitioners. You've got my financial responsibility information in there and maybe some medical documents. Perhaps you've got all my authorizations in there, maybe a piece of paper. So security, portability, reporting, data collection. It's not an EMR. This is a data set coordination purgatory. And when we get involved with this stuff, the construct of the contracting and the stipulations of the contract, you have to contain an important idea, indemnification for the employer, because the employer cannot be expected to know what Jeff knows or what they're working on. And some of the areas where there are just absolute landmines and sinkholes that Stephanie talked about the employer can be insulated from if they've got the appropriate indemnification. Okay, next slide. The RFP is where you start. And I would stress the fact that the EMR or medical record or whatever you want to call it, EHR, PHR, PMR, is not a practice management system. Your practice management system has functional information, your scheduling stuff, and it is generally not a patient wellness system. All of these wellness apps have their own separate stuff. And if you have we looked at a operation the other day that had 7 different healthcare kind of sort of quasi providers on site, besides their on-site program, PT and smoke stoppers, and they had their EAP and everything else. Nothing articulated. Also, the patient EMR, EHR, and their patient access profiling material did not articulate. They were separate to a fault, but separate, and everyone recognized it. The clinic EMR is not necessarily an OCHealth tool unless it's an occupational health EHR. Enterprise is, others are, very few are. So if you've got an OCHealth system or program, I would not, and I invite Jeff's comment, automatically think that it is your EMR platform for your primary care. But again, Jeff's going to correct me on that in a minute. Your independent providers are also churning out medical determinations and creating records all the time. The on-site coordinating body, whoever it is, if it's a TPA, a insurance program, on-site, they're supposed to be collecting that stuff. So we've got adequate care management tracks, and we can actually take some of the disease categories that are really going to be affected by an appropriate primary care intervention and jump on some of the people who are probably going to be high cost users of our healthcare system and our healthcare benefit. EAP, addiction, protected classes, behavioral, all of them are worthy of their own separate I guess, categories of concern. And some of them, I don't know if they should even be on site. EAP is a question I come up with all the time. Behavioral, the new standard for that is telehealth merging with behavioral, creating a whole new opportunity for hazards and for informational leaks and for concerns about protected information and covered entities. I guess the joke is always you're a covered entity until you determine by until the judge says that you're not, because everybody concerned, all patients believe that they're going to have protection. I don't care what Stephanie's slide number 8 said. You're not off the hook until you really have permission in your hand for the patient information to be disseminated. Let's try the next slide, Stephanie, please. This is the dream that the EHR collects all sorts of stuff, the EAP, health, wellness, HR. I could have put a lot of different boxes on here, but it gets too busy. I want to demonstrate a concept. The next slide, that's the possible, the EHR. The next slide is really what is kind of sort of practical, in which we have to work on some more. And the thing that's going to help us work on this, two things that we haven't talked about yet, artificial intelligence and blockchain technology. But this is where everything communicates with each other. All these little databases are hooked up somehow with little tiny arrows. I don't know if EAP belongs in there, but Jeff would tell us what parts of Occ Health belong in that circle, what belongs outside the circle for good reason. But next slide, we'll talk about blockchain in a second, if you would please, Stephanie. So that's the practical application. But what's really happening, Stephanie? Give us the next slide. All these things are in different zones, different areas, and you've got to have control and separate contracts and separate arrangements and separate protocols for each. EAP is the most employee assistance programs, the most obvious to everyone on this call. But the EHR, electronic health record, may or may not include any of those. It needs some information from each of them. Occ Health and EHR are the most closely organized. That's the reason I put the two colors together, to signify that they kind of sort of go together. But Occ Health, for good reasons, maybe going back 150 years to company doctors in the company towns, by the states and by the OSHA requirements and stuff like that, are necessarily separate from hired doctors that work at the hospital. Next slide. Information hazards, control and access, present hazards to the employer. Control and access presents hazards to the employer. these present hazards. They also present opportunities for the on-site program. Coordination has definite benefit for the patient. I don't want to go someplace and not have my EMR, find me, or my medical information find me, or my doctor treating me or giving me my prescription not understand what happened to me last year. But how much control does the employer want to have, and how much risk are they going to assume? My concern is for vendors or partners that we have involved with our EMRs, do they have a compliance plan, and is it effective? Can I be indemnified under that compliance plan? We suggest at the employer level, that there be a medical patient information czar or oversight person or compliance officer that works closely with the HR people and with the vendor to make sure there are no leaks, stumbles, problems, or issues. This is somebody with a lot of experience and a lot of information and very, very savvy about how these things work. Next slide, we'll show you who not to do. You don't want somebody who's not literate in all of these things, somebody who's not up to date, somebody who's not reading and working with the people like Jeff and Stephanie and conversive in the language of EMR and EHR. Next slide. So what do we say, or how do we look at this stuff? Well, face some realities. Blockchain is going to come along and change this and make us all crazy. This is to Jeff's point. If you have been excited about all the changes this past year, you've not seen anything yet. The EMRs don't always work the way they're supposed to. So they had a lot of promise, and they've had a lot of work, and there's been a lot of investment. And I wish Google luck. I did meet with some years ago, the medical director for Google, met with the guy out at a big Cerner event, and he said, I asked him how they chose what they do. He said, well, we take the most impossible things, and we have all the stuff that we need to do it with unlimited access to programmers, et cetera, very confident, because he was out at Cerner learning about what they were telling their clients and learning about EMRs from guys who knew little about it, guys like myself. And but going back to craft this huge EMR solution for the world. And I'll be darned if they didn't drop it after 2 years. Demo, shop around for the right EMR for your clinic. That's absolutely something that well covered by my colleagues. But are you shopping for the EMR? Are you shopping for the vendor and getting the EMR? I don't know. Employees don't want their employer to have access to medical information. So I reflect on Jeff's comment that some employers are really, really trusted, and some employers are really, really not trusted. We work with unions, and we worked with one employer where we had 6 unions, and we were installing an on-site clinic. And I asked the HR VP for why they had 6 unions. I couldn't figure it out. He said, well, it's because we deserve it. And the employees did not trust the employer at all. And they had clinic independence by design. They even had people from an outside firm cleaning the clinic because the employer wanted to make sure that every employee knew that their medical information was not going to be compromised. And that was really the only way they felt they could grow the process. We live in a litigious society, getting worse. These rules and regulations do not help. I think maybe that's an unfair statement. The rules and regulations understood by competent counsel do help us navigate this, but it makes things more opportunity for litigation to occur. There's new exposure for employers who are developing on-site programs, and control and access of the information has to be balanced against the need for enrollment and utilization. This was a point that Jeff made, which I think I'm highlighting. He said it, I think, a little bit more clearly than I do. If you've got bad rap on patient privacy and control of information, then people won't use the clinic. You need more information to the employees and more security, and they need to know how safe it is. Then I would only say that the vendor contracts have to refer to some significant red line issues. Where does the employer responsibility stop and the vendor responsibility emerge? Very important. And I would only add that I appreciate being involved in this and contributing. I think that I learned a lot from Stephanie and from Jeff in the time previous to this, setting this up. So important information. Thank you all.
Well, this is great. Thank you to Stephanie, Jeff, and Michael. We only have a few minutes left. I'd like to go around the table for those who are still on the webinar and see if there's any questions. So when I call your name out, if you have any questions, please let me know. So D. Daly, D, do you have any questions or comments for the group? D? No? Okay. Let me ask Emily Starry, you have any comments or questions, Emily?
I don't, thank you.
Okay. Kenneth Larkin, Kenneth, any comments or questions for the group?
Maybe just a quick one for Stephanie. I don't know if there's anything that you might want to indicate for those providers at on-site clinics who may have access to both sets of records, both the employer and then things that are strict that are medical on the outside. I know they only give you 4 minutes for a 3-hour talk, but just wanted to give any quick words of wisdom for the employer and the providers in terms of what cautions they need to take.
Yeah, that's a really good question. And, you know, as Mike and Jeff talked, I kept thinking of all these things I didn't say, like substance use disorder records and Part 2 and all the access issues there. So I really think one of the things that either Jeff or Mike said is that the policy should drive here. And I really think it starts with really well-defined policies and roles. And so you may have times, especially if you're doing primary care and OC health, where you do have an employer that has you know, different access, or the provider may also be an employer. Like if you're at a hospital, provider is also the employer, right? And so I think having really well-defined roles, policies, procedures, and then I think training is key, because you can have those policies, right? But as far as the access goes, if there's not good training on what they should not be accessing, it kind of goes out the window too. And hopefully using an EHR that is able to define roles and capabilities. But I know when we work with employers and consultants and EHRs, you know, and especially like if you're a health system, we literally like map it out where we will have the record, what it is, what laws govern, who needs access, how they get access, and we'll get into really what I think are complicated data flow charts. And even though they're complex, it really helps drive that access discussion.
That's awesome. Thank you.
Mm-hmm.
All right, well, I guess there's no other questions at this time. So again, let me thank Stephanie Erkely and Jeff Donnell and Michael LaPena for a very comprehensive overview of really a key area for worksite centers, employers, and their partners. So thank you all very much. This has been recorded and slides will be available. We'll look forward to seeing you at our next program. Otherwise, have a good week and stay safe. Thank you, everyone. Bye-bye.
Thank you, Larry.
Bye. Thank you.